this video, we will be discussing on the human immunodeficiency virus or HIV and its management. I'll be covering on the following topics: HIV and its prevalence, the classes of drugs used to treat HIV, is there a possibility of a HIV vaccine, the impact of pre- and post-exposure prophylaxis, and the problems faced in managing HIV. 27-year-old Ethan dabbled with intravenous drug use in the past, but has been clean for the past 2 months. However, over the last 1.5 months, Ethan has been feeling rather uncomfortable. This was attributed to him suffering from flu-like symptoms such as fevers, joint aches, weight loss, and severe headaches. He also noticed ulcers in his mouth. What do you think is wrong with him? You have guessed it right. Ethan has unfortunately contracted HIV. Misinformation and a lack of knowledge around HIV continues to perpetuate stigma. Misconception around HIV includes statements such as HIV will definitely lead to death, HIV can be transmitted by kissing, and confusing HIV with AIDS. Throughout this video, we should be able to clarify some of these common myths and misconceptions around HIV. HIV is a major global public health issue, and AIDS-related illnesses has claimed more than 32 million lives so far. In 2018, Singapore reported 330 new cases of HIV infections, bringing the total of 8,295 people. However, HIV is not a death sentence and can be managed. To understand why, let's go through some concepts.
HIV refers to the human immunodeficiency virus, which is a kind of retrovirus that affects human T helper lymphocytes, which are a part of the immune system, lymphocytes that express the CD4 cell surface receptor. The HIV virus infects the cells and replicates within them by injecting or inserting its viral DNA into the host cell nucleus, going on to start a cycle of replication within the cells, ultimately killing the cells when they are released from the host cell. These viruses then go on to infect other cells, setting into place this cycle of replication, eventually without treatment, causing the immune system to weaken as a whole. A subset of these infected cells with the HIV virus may actually go into a clinically latent stage, wherein there's no ongoing active viral replication and no immunosuppression. However, even these clinically latent parts of the cell may at any point reactivate, setting into motion again the cycle of viral replication and immune suppression. Over time, without treatment, people with HIV infection may have their immune systems weakened to the point where they're not able to adequately protect themselves from infection by viruses, bacteria, fungi, and parasites. HIV is spread through contact with infected body fluids. It's called a blood-borne virus for that reason. Body fluids that may potentially contain high levels of the virus or have a high viral load may include blood, sexual fluids such as semen and vaginal fluid, as well as breast milk. Hence, the modes of transmission that may potentially cause HIV to be transmitted from an HIV positive to an HIV negative individual include unprotected sexual intercourse, especially if the HIV positive partner is not on treatment and therefore has a high viral load in his or her body, through the use of sharing of needles, especially if people are having intravenous drug use, or from mother to child, either during pregnancy, during the process of childbirth, or after childbirth when the mother is breastfeeding the new infant. It's important to also remember that because it is a blood-borne virus and requires contact with infected body fluids, HIV cannot be easily spread through other means, especially where it's just casual contact, such as holding hands, kissing, sharing of utensils, sharing of food and drinks. It cannot be transmitted from the bites of mosquitoes. It cannot be transmitted through the shared use of toilets or other sort of common appliances around the house. It's therefore very important for people who are HIV infected to get diagnosed as soon as possible, start on treatment to reduce the viral load and reduce the risk of transmission. People who are infected with the HIV virus may develop symptoms soon after exposure to the virus. Between 50 to 90% of HIV-infected individuals may develop what we call acute HIV infection or seroconversion illness, usually 2 to 6 weeks after being exposed. These symptoms are actually very similar to a viral illness and may include symptoms like fever, rash, sore throat, swollen glands in the neck and the armpits, as well as severe headache or even ulcers in the mouth and the throat. These symptoms are very similar to what Ethan is experiencing right now. Even without symptoms, HIV replication continues to go on inside the body. With time and without treatment, as the T helper lymphocyte count starts to drop as the HIV virus continues to relentlessly attack them, people may develop symptoms that reflect ongoing opportunistic infections that are occurring because the immune system is so weak. The type of symptoms that patients get will depend on the types of infection that they have. If they are lung infections like pneumocystis pneumonia, they may present with cough, fever and shortness of breath. If they are brain infections such as cryptococcal meningitis, the symptoms that they present with will include headache, blurring of vision and fever. So it really depends on what opportunistic infections we're talking about. And the aim is to really try to reverse these symptoms by getting people on treatment and having immune recovery take place. HIV infection is diagnosed through the detection of HIV-specific antibodies and antigens. This is done through blood tests or oral fluid tests of an HIV-infected person. After being diagnosed with HIV infection, it's very important that the HIV-infected individual is linked to care, such that HIV medications can be started as soon as possible. This is done because we want to get a person's HIV viral load undetectable as quickly as possible. Viral load testing basically means the detection of viral levels within the bloodstream of an HIV-infected individual, and getting it to undetectable means that the patient's immune system has a chance to recover and the risk of transmission onto others is minimized. The treatment of HIV infection is through the use of antiretroviral therapy, or ARTs for short. ARTs work by suppressing viral replication and therefore suppressing the viral load, allowing for immune recovery to take place through the recovery of CD4 cells, protecting the health of the HIV-infected individual in the long term. All people who are diagnosed with HIV infection should be started on antiretroviral therapy as soon as possible and maintained on this treatment lifelong to make sure that they have long-term benefits to their health. There are actually many different classes or families of antiretroviral drugs. These medications all work at various or different stages of the viral life cycle or the replication cycle. And they may include drugs that work on viral reverse transcriptase, including the nucleoside or nucleotide reverse transcriptase inhibitors or the NRTIs, the non-nucleoside reverse transcriptase inhibitors or the NNRTIs, drugs that work on viral protease such as the protease inhibitors or chemokine receptor inhibitors, fusion inhibitors, and the latest, most modern class of drugs, the integrase strand transferase inhibitors. Antiretroviral therapy needs to comprise drugs that come from at least 2 different classes working in combination. This allows for an increased chance of drug efficacy and a reduced risk of developing resistance to any one of the drugs in the combination. Now, because there are so many different kinds of HIV medications out there, and because every patient is different, many factors come into play when we're deciding on which combinations of antiretroviral drugs will work best for any given patient. These include things like what the pre-treatment viral load is, whether it's high or low, what's the pre-treatment CD4 count, once again, whether it's high or low. Factors such as whether the virus is already resistant to any given medications also needs to be considered. Whether the patient has any pre-existing medical conditions, especially those that affect kidney function and liver function, are also important, because with long-term treatment that we need to give with HIV infection, we need to be sure that these are taken into account. Last but not least, any patient factors or considerations, such as the pill burden, whether there are any cost considerations, all need to be carefully considered together with the patient before we decide which combination of drugs will work best for any given person. Now, there have been continual efforts at trying to develop an effective HIV vaccine ever since the discovery of the HIV virus as the cause of AIDS in 1983. Unfortunately, the road to discovering this vaccine has been filled with challenges and pitfalls for a few reasons. First of all, human beings just do not develop natural immunity to the HIV virus even after being infected, making effective vaccine development quite difficult. Secondly, the HIV virus is really quite notorious for mutating very rapidly, once again making the development of an effective neutralizing antibody quite challenging. Third of all, we don't have an effective animal model for the disease, and this makes the development of the vaccine quite challenging as well. However, this is not to say that there have not been successes in the past. The investigators behind the RV144 trial in 2009 reported that they had actually developed a vaccine that had a 30% effectiveness in human subjects. And to date, there are still 3 large ongoing trials looking at vaccine discovery all around the world. So I would say that it's a space that's quite promising and that we should be seeing good results in the near future. Now, as with most things, prevention is always better than cure. And in the field of HIV prevention, one of the latest and most exciting innovations is that of HIV pre-exposure prophylaxis, or PrEP for short. HIV PrEP refers to the use of a combination of 2 antiretroviral medications, namely tenofovir and emtricitabine, co-formulated into a single tablet and taken regularly by people who may be at high risk of being infected by the HIV virus. These include people who may not be able to use condoms correctly or consistently, or sexual partners of people who are HIV infected but may not yet be on HIV treatment and therefore might have a high viral load. The use of HIV PrEP has been shown to be highly effective in the prevention of HIV, especially when used together with other strategies such as the correct and consistent use of condoms. Now, it's important to note the differences between HIV pre-exposure prophylaxis, or PrEP, and HIV post-exposure prophylaxis, or PEP for short. As I said, PrEP refers to the use of a combination of 2 antiretroviral drugs, tenofovir and emtricitabine, before being exposed to the HIV virus in order to prevent infection. Whereas post-exposure prophylaxis, or PEP, refers to the use of a combination, usually of 3 antiretroviral medications together for at least 4 weeks after being exposed to the HIV virus through a high-risk exposure. HIV post-exposure prophylaxis has been shown to be highly effective, especially if taken correctly, and started within 72 hours of the high-risk exposure. Hence, it's important that anyone who may have potentially been exposed to the HIV virus seek medical attention within 72 hours of that exposure so that HIV post-exposure prophylaxis may be started if necessary.
The biggest challenge to HIV management is virus resistance. A WHO HIV drug resistance report surveyed countries in the continents of Africa, Asia, and Latin America. In 6 out of 11 countries, more than 10% of people starting antiretroviral therapy had a strain of HIV that was resistant to some of the most widely used HIV medicines. HIV drug resistance is most often a consequence of people not adhering to a prescribed treatment plan. Side effects and lifestyle restrictions for the selected drug regimen, the patient's will to fight HIV, and the lack of support in patient social circles all work against adherence. Poor adherence to ART, either with occasional missed doses or taking half doses, is associated with less effective viral suppression, which risks the immediate health of the patient and risks creating permanent treatment resistance, which will then lead to downstream effects of the treatment costs and therapeutic options. If the patient is left untreated, the patient may also transmit drug-resistant viruses to others. New guidelines published by WHO call for countries to consider alternative treatment regimes when drug resistance surpasses 10% nationally. In these instances, dolutegravir is the preferred drug of choice, an integrase inhibitor with a high barrier to resistance. However, ensuring compliance is crucial to global war against HIV. Another therapeutic challenge in HIV is polypharmacy, especially in older patients. This can result in decreased adherence and adverse effects or drug interactions, which diminish the life-preserving effectiveness of ART drugs. Future research efforts to tackle polypharmacy should be focused on determining the safety and efficacy of combined ART regimens in older patients and their long-term effects. In summary, these are the learning outcomes that you should take away from this video. Number 1, HIV is a virus that attacks CD4 cells and thus breaks down the person's immune system. Number 2, there are 5 classes of HIV drugs and they constitute to ART. Number 3, there is a possibility and hope for HIV vaccine. Number 4, challenges includes virus resistance, polypharmacy, and non-adherence. HIV can be contracted by anyone. With early detection and adherence, they will be the key factors to lead to successful treatment outcomes.